Thanks for inviting me to talk. I changed it up a little bit. I know that on the schedule it's angioplasty and stenting. There's a lot of new information out from the recent CREST trial, so I'm still working on that talk, so I thought I'd change up a little bit and talk about spinal vascular malformations. Hope that's okay. I had no relevant disclosures for this particular talk. So, first off, what do we mean when we say spinal vascular malformations? Well, there are several types. There are intramedullary AVMs, akin to AVMs that we see in the brain substance. Perimedullary AVS. So these are fistula along the surface of the cord, and they have a couple different presentation types. And then dural fistula of the spinal canal, and those are akin to dural fistulas of the head as well. And then there are extradural arteriovenous malformations and arteriovenous fistula. And finally, there is one syndrome called Cobb syndrome or metameric angiomatosis, where there's a vascular malformation involving all levels of that particular metamere or somatome. So in the spine, the consequences of the AV shunting are either hemorrhage, so if there's a aneurysm or weakened vein, hemorrhage can occur, and that's seen with perimedullary fistula and AVMs. I'll get into that in a minute. Venous hypertension is not uncommon with dural fistula. In fact, that is the method of presentation. So elevation of venous pressures leads to poor drainage of the spinal cord, leading to neurologic deficit. And sometimes there are tremendously enlarged vascular structures that can lead to mass effect in the limited space in the spinal canal. And arterial steal, maybe. That's always discussed whether that actually occurs or not in the spinal cord. So as you're familiar with the anatomy, there's each segment has its own arterial arcade. The aorta starts out to the left of the spine in the after the transverse arch of the aorta, and then slowly winds its way anterior to the spine in the lower lumbar region. So at each level, though, there is a right and left radicular artery or segmental artery, which then serves all the elements of that dermatome, somatome, and those paired arteries then are seen on the aortogram as they face to the right at the posterior aspect or posterior lateral aspect of the aorta, and then they march down sequentially, becoming more aligned with the vertebral body as the aorta comes more anterior. The primary blood supply to the spinal cord is the anterior spinal artery. And the anterior spinal artery has typically a network of feeders associated with it. Not a pointer, do you? Okay. Oh, so no pointer. All right. So that's fine. I'll keep my hands behind me. So the anterior spinal artery has a primary supply within the thoracolumbar region, and we call that artery of Adamkiewicz, which I can never spell well. And that occurs very classically 60% of the time from T9 to L3. So it can be quite variable where it arises. But that supplies the vast majority of it. Once we get to the cervical region, there is typically one vessel, but there may be multiple, serving the cervical region. And often we call that the artery of the cervical enlargement. But there can be multiple vessels. In the cervical region, it's typically fed from the vertebrals or the thyrocervical trunk or costocervical arteries. And at the junction of the two vertebral arteries as they form the basilar, there's that unique sort of quadrangular configuration of the two anterior spinal arteries, as you see on the top of this figure, coming down, joining together, and forming the anterior spinal artery. So the primary supply to the spinal cord is quite limited, with very few arteries serving a very small but extensive anterior spinal artery network. And that supplies the anterior portion of the cord, basically 2/3 of the portion of the cord. The posterior columns are often more often fed by the posterolateral spinal arteries, which again have a segmental distribution, typically more like a web of vessels that connect up and down, right to left, but don't typically form a long continuous chain like the anterior spinal artery. And here we see the aorta anteriorly, and this is again looking from above. So the aorta typically rests to the left of the vertebral body, and more left is in the higher thoracic region, and then more midline in the lumbar region. But we have the arteries arising from it, the sometimes called intercostal, I call them segmental arteries, paired each side, running around the vertebral body, feeding the vertebral body and the paravertebral musculature, eventually going out and feeding the transverse process and rib. And so right underneath the rib is typically where the intercostal artery itself runs. There are various branches to all that segment, and the ones we're most critically concerned about are the ones running along the posterior aspect of the vertebral body in the epidural space, because you can have vascular malformations there, and of course the radiculomedullary artery running along the nerve root into to obtain access to the spinal canal. And then if there is a significant portion going anteriorly to feed the anterior spinal artery, then in the thoracolumbar region, that's Adam Kevitz. But all typically have that posterior branch you see contributing to the posterolateral longitudinal arterial trunk, which again, as I said, is not necessarily continuous. This is a higher view of that spinal cord itself, anterior spinal artery. And this figure, it's called the anterior median longitudinal arterial trunk, just because the more syllables, the better we sound. But you see it goes into the central sulcus, dives deep, and then penetrates through the cord. And that is why it supplies so much of the cord, 2/3 of the cord, with the posterolateral spinal artery really filling the posterior aspect of the spinal cord, and about 1/3. And then, one posterolateral spinal may be big on one side and fill both sides, or fill from a segment above or below. And because it's a filling less of the cord and it's more of a network, that's why we can get away with blocking off at least most posterior lateral trunks. But some will be quite large and supply a very significant portion of the cord, and then we get a little bit anxious about that. But you can see that posterolateral spinal artery, of course, follows and the anterior spinal artery follow its relevant nerve root to get that access. Again, this is sort of a diagrammatic view looking at the anterior spinal artery and the typical hairpin turn. So this is quite critical to recognize this on angiography. It takes that hairpin turn, has a descending portion and then an ascending portion. And then the posterolateral spinal arteries just follow the dorsal nerve root serving the posterior aspect of the cord. Occasionally, with a large intermedullary AVM, we can see those the branches diving deep into the sulcus. We call those sulcocommissural arteries. Occasionally, those can be quite large and actually be catheterized independent of the anterior spinal artery, and embolization can be achieved, but it has to be quite large. And during embolization, any reflux has to be critically avoided to block the anterior spinal artery. Really very poor collateral supply to the anterior spinal artery. And this injection, you can tell it's in the higher thoracic region because the radiculomedullary artery obviously follows the nerve root, and so higher we go, the closer the nerve root is to its arterial supply on the exiting foramen. So as your nerve root gets longer and longer as you go lower into the lumbar region, you'll see that artery pedicle following the nerve root is more horizontal in the thoracic region, more vertical in the lumbar region. But that's typical hairpin turn we'd normally see with the anterior spinal artery. And in a properly aligned angiogram, that would be directly in the midline. You can have some that look like a hairpin turn that are off midline, and those would be posterolateral spinal arteries, but this is the typical anatomy. And there'll be more pictures of that later. Yes?
What's that other hairpin turn?
Oh, that's the catheter. Okay, we use typically we have to use a back curve catheter because the aorta is so big. We use a catheter that has it has an up curve and a down curve, and that position allows us to seat it well in the aorta because it's wide, but it has a slight upturn because the segmental arteries typically have that configuration. And then as we see the medial portion going up and down, the hairpin is the anterior spinal, and then the major branch going laterally is the intercostal artery. And the branch going down, angling down from your right to left, is going to be a posterior branch serving the posterior elements and paraspinous musculature in that region. Okay, so now how about some pathology? Intramedullary AVMs, very similar to brain AVMs. Typically they present in childhood or young adulthood and present with acute symptoms, hemorrhage in 50%, occasionally focal deficits. And the hallmark of the presentation is a stepwise evolution of symptoms. So they will start out normal, have a hemorrhage, decline. Go for a while, another hemorrhage, decline. So it's a stair-step progressive worsening. And the AVM is a discrete nidus, and it can be located anywhere in the spinal cord. Here's an MRI. We see on the top panel the nidus, that tangle of blood vessels, and then on the lower panel we see some of the draining veins. And that's typical for appearance of any vascular malformation of the spinal canal. Intradural component is these enlarged draining veins, serpiginous structures. The spinal veins are mostly dorsal. There are some anterior, but mostly dorsal, and so you get these large serpiginous structures. So the nidus and the draining vein. And the corresponding angiogram. So again, you'd ask about that catheter. So you see the catheter is entering into the segmental artery. The intercostal artery is again following the rib to your right. Other branches, but you can see that hairpin turn going up and down, and then on the frame to the left, you see there is an additional branch going up parallel to the anterior spinal artery, and that is actually in this particular patient has both on this one injection an anterior spinal artery and a posterolateral spinal artery, and so you can see on the midline view how that hairpin is directly midline and how the posterolateral spinal artery is going to be off the midline, perimedian. And of course you see the nidus of the malformation. Early phase, and on your right, the later phase showing the venous drainage, those serpiginous structures we saw on the MR. You also see that anterior spinal artery coming all the way down on the right picture, going down to L1, and then you see a branch going up. So that's called, that as it goes down to the bottom, it comes back up. We call that the arterial basket at the tip of the spinal cord. So it will come down, go posterior, and also serve the posterior portion of the spinal cord. And this is after partial embolization. We can see that the anterior spinal artery axis is maintained, but the posterolateral spinal artery has been embolized. Further embolizations. Now that it's been cleaned up a little bit, although you do see a sulcocommissural artery feeding the AVM just after the hairpin turn, that vascular structure. But now that it's cleaned up a little bit, you also now see the ascending portion of that anterior spinal artery. So we have the hairpin loop and the ascending portion. So that's a very typical anatomy. Another case, a hemorrhage. large vascular structures in the axial. And here's the angiogram. So directly AP, we see a posterolateral spinal artery. Notice that it sort of looks like a hairpin, but it's not quite. It's too abrupt, goes directly up and down, and then feeding the malformation before and after embolization. In that same patient, in a different segment, now we do see the anterior spinal artery. This is rotated a little bit, but it has that typical, on the right side, we see the typical hairpin turn and the ascending limb going up, very classic. And you see it typically is not quite right at the apex of that hairpin. It's just always a little bit to the side. Again, that's filling the AVM, and that's how we approach these intramedullary AVMs. Is we embolize those branches which we can, like the posterolateral spinal. But if we can get into a branch from the anterior spinal artery, as in this case on the left side, we see that ascending limb, and we see an additional sulcal commissural just to the left of it. That was accessed and embolized to achieve some embolization of the AVM, but avoiding the ascending limb of the anterior spinal artery. So this is embolization through the anterior spinal artery. Difficult, possible in some cases if the access is correct.
Aaron, what do you use to embolize?
It depends. So if we have in the past, when we cannot get selective and it's a very high flow malformation and we're trying just to reduce flow, we can do flow directed embolization, allowing the particles to be directed into the AVM. There is some risk that once you reduce the flow too much, it'll start going to the anterior spinal artery. So we prefer to use liquid agents and super selectively catheterize into the actual feeder branch, just like we do for brain AVMs. So more often glue and more recently onyx material into that. So that's all about safety of position, though.
What's the rate of recanalization?
Well, for intramedullary AVMs, we're not really curing these, rarely curing these, because they are typically fed from the anterior spinal artery, because we're talking about 2/3 of the blood supply to the cord. So it's always involving the anterior spinal artery, and that's the difficult part for us. So most of these are treated either in combination with surgery or radiation, or not treated at all when it's impossible to treat. So it's very rare, even rarer for us to cure a spinal cord AVM than it is for a brain AVM, just because of the type of supply it has. Sometimes there may be associated findings, an aneurysm, something like that we can treat, that may be a focus of bleeding.
So depending on the embolic materials, you have to do it with particles, it's giving more transitory treatment.
True, likely to recanalize.
What exactly is onyx made of?
Onyx is ethylene vinyl alcohol. So it is suspended in a solvent, dimethyl sulfoxide. So they're both organic materials. And you inject it, you actually fill your catheter with dimethyl sulfoxide to make sure it doesn't precipitate in your catheter. But dimethyl sulfoxide rapidly diffuses in an aqueous solution. And so once that is gone, the material, ethylene vinyl alcohol, precipitates out of solution because it's not soluble in an aqueous solution. And that's how it works, by precipitation, as opposed to NBCA, which is actually polymerization. It's a glue. So the advantage of that is we generally have a longer working time with onyx, but there's still a role for both because of the different handling characteristics. And the one thing we always caution, for preoperative embolization is monopolar cautery with onyx. There can be some sparking. Have you done that?
Yes, especially for meningiomas, when we try to do some embolizations, you have the sparks on it. You're using anesthetic agents that can be flammable and produce a fire. But with the bipolar, there's no problem with onyx.
Yeah. So, for instance, for our head and neck colleagues, we often avoid the use of onyx because they use such or for peripheral AVMs, more common. All right, Cobb syndrome or metameric angiomatosis. So this is here because they will have an intramedullary AVM, but additionally, because it's a segmental disease, they will have vascular malformations of all segments. So the very similar related syndromes are Klippel-Trenaunay and Parkes-Weber. So here's a patient has a shoulder AVM, hand AVM, intramedullary AVM that was embolized. So in the same segmental distribution. So in the cervical cord all the way down to the hand.
And those can also extend into the vertebral bodies and some of the other soft tissues around.
Absolutely. You can have an epidural vascular malformation, paraspinal vascular malformation, bony vascular malformation as well in those patients, the entire segments at risk.
For the residency boards, they used to like the classifications that some of the neurosurgeons have proposed, and those that are associated with the Cobb syndrome that are usually called juvenile to have a tendency to appear in younger people are what they call the type 3. And the first type that you have been referring to, that is the EL or parenchymal arteriovenous malformation, it used to be called also type 2.
Juvenile. Second type I'd like to talk about is perimedullary arteriovenous fistula. Now these are vascular malformations on the surface of the cord. So this is entirely different. Don't have to dive into the cord to get at these, so these are surgically accessible. But there are two different subtypes of this. Those with a small arteriovenous communication and those with a large arteriovenous communication. Those that are large typically present as an infant. There will be an acute presentation because there's a high flow, large volume shunt. They may present with mass effect due to the enlarged veins or hemorrhage. And the ones that are smaller present very similar to dural arteriovenous fistula because the size of the shunt is small. They don't get hemorrhage or mass effect, but they do get venous hypertension because of progressive neurologic deficit. So a couple examples of those. Although both have a poor natural history, treatment is more feasible than with intramedullary AVMs. Large AVFs, primarily embolization, unless it's not accessible, but generally because of the large size, the arterial feeders are large enough that access can be achieved. The small perimedullary arteriovenous fistula can be difficult to access, or more often can involve the anterior spinal artery as the primary supply, so it becomes difficult for us to embolize, so surgery is often necessary. This is one such case, so we see a selective injection and this AV connection along the surface of the cord with a large varix associated. And this is after catheterization and embolization. We have embolic material within the varix. This is the venous drainage of that perimedullary AV fistula. It's quite extensive, and this is the same thing we see with dural fistula: is venous hypertension, poor drainage of the normal cord. Again, that's the super selective. I guess there are a couple. So this is post-embolization. This is a late phase. There it is. There's the microcatheter in place with the injection material into the varix at this point at the level of the AV fistula. And this is the posterolateral spinal artery, right? It's off midline. So this makes it feasible to treat this lesion. And this is the anterior spinal artery afterwards, showing that that's intact. Okay, this is the other type. That's a large AV connection. So we can see the segmental artery injection. You can also look at the bone so you can see it's a child. Segmental injection, large arterial pedicle coming up and around and down, and eventually you see that varix, which you also see in the MRI on the left-hand side. It's very difficult. Multiple injections had to be done to map out exactly where that AV connection is. But you can see typically there's a transition point in any AV fistula where you have an artery going to a vein, and we can see that just to the left of that large barracks, that transition point between the artery, which is narrower, and the vein, which is slightly bigger. So multiple injections were done to map it out. So we can see in this injection, we fill the conjoint arterial pedicle that was seen from the other branch, and that smaller, more medial branch coming down right above that transition zone between the artery and the vein, which is not typical. So the problem is if you block the artery proximal to that, it will continue to fill from this smaller branch. You have to really identify that AV connection. And so here's the mapping, and again, so in red on the right-hand side in the pictogram is where the arterial pedicles are, and then where the AV connection is. And that's usually a good hint, that change in caliber. So multiple arteries came in, just like any fistula that sucks in any blood from wherever it can. And am I going backwards? What is it doing that? Okay, and so then supraelectric catheterization, this is an older slide, obviously. So a balloon was placed in that AV connection, and then this is on the left is the immediate, so we see some still filling of the arterial pedicle, which is enlarged, and this is delayed on the right. Several, I think it was 3 months later, injection showing complete eradication of the fistula with normalization of the arterial pedicles. We actually see right at the base of T12, there's a little angled radiodense object. That's the balloon that is subsequently deflated over time, but the large venous structures have thrombosed, so there's no recurrence of the fistula. Dural fistula. This is some more common disease. It was first specifically identified by Kendall in 1977. It's a small dural arteriovenous shunt draining into the perimedullary veins right at the nerve root sleeve. And it's normally seen thoracic and lumbar levels, can be seen anywhere though. And the pathophysiology, similar to the small shunt perimedullary fistula, the symptoms are caused by venous hypertension. So for whatever reason, the radicular veins, their drainage is impaired. You have the fistulous connection, but it doesn't drain in the normal thoracolumbar region below the level of the fistula, and so those outlets become thrombosed. Not too dissimilar, sometimes we see cranial transverse sinus fistula eventually have a thrombosis of their outlet at the jugular sigmoid. And with that outlet occlusion, high flow into the perimedullary veins, drainage has to ascend. So we typically see a fistula with upward drainage that leads to venous hypertension in the lower cord and progressive symptoms as more and more of those outlets at each segmental level of thrombose. There is a term foie à la joanine, ascending necrosis of the spinal cord. Probably that was a long-standing dural fistula. This is typically seen in men more often than women, 50s to 60s. The saying is, you get this old couple come in, and she goes my eye, he goes my back. She has a cavernous sinus dural fistula, far more common in women. He has a spinal dural fistula, but same age group. The presentation is a cauda-equina or conus syndrome. So typically sensory dysfunction followed by motor dysfunction and bowel and bladder dysfunction and erectile dysfunction. So and you have progression, and it goes stepwise, level by level by level, as that venous drainage becomes impaired at each segmental level. And if left untreated, patients can paraplegia or worse over 6 months to years. Depends on the severity of the drainage. I actually had one patient who had a fistula that had progressed so far They were having respiratory difficulties because the diaphragmatic muscles were paralyzed. But because it's primarily sensory and it's slowly progressive, and these patients are in their 50s and 60s, these patients are often misdiagnosed as having spinal stenosis or a polyneuropathy, and don't come to eventual attention by the relevant specialist for 6 months, a year, 2 years. This is a unfortunate specimen, but we see the arterial feeder in red and the venous structures in blue in the pictogram on the left. But right at that nerve root sleeve, we see the enlarged vein at the nerve root sleeve level. So operatively, you identify that, I guess, entrance point into the intradural space of the vein, clip that vein, and that's it. That vein should collapse in size, and that should take care of it. Dural fistula, sorry. Diagnosis is typically by MR and CT, now MRA and CTA. On the diagnostic images, we see cord edema, or in CT, cord enlargement, unless it's a very long-standing disease, in which case you'll see the cord shrink, or you'll see a syrinx develop within the cord. The standard image should show some flow voids, particularly dorsal, as the veins are primarily dorsal. And with both, high-resolution studies may actually show you the site of the fistula. Myelography is not used much anymore, and in fact, patients who have surgery to open the spinal canal, open the dura, will typically get worse because you change the pressure dynamics and you've worsened the venous, acutely worsened the venous pressures, and after surgery they're often worse once you open the spinal canal if you haven't addressed the dural fistula, and that's also occurred with lumbar puncture. The MRI shows cord edema and some flow voids, both dorsal and anterior to the spinal cord, and this is a typical finding for dural fistula. Angiography is the gold standard currently, although MRA and CTA can be quite effective. We prefer to do selective injection of the segmental arteries, but sometimes because these patients are older and have atherosclerosis, we may need to do aortic injections. You don't see as well, though. But sometimes there's maybe some subtle findings. We're not sure. The patient has no other explanation for their symptoms, and we're asked to do a spinal angiogram. The spinal angiogram is considered negative for a spinal dural fistula only if two things occur. One, we don't see a dural fistula. But two, we inject the anterior spinal artery, the artery of Adam-Kevitz, and see a normal arteriovenous transit time. Because a normal arteriovenous transit time excludes venous hypertension. So if you don't see the venous structures within about 10 to 12 seconds, if it's longer than that, then you just haven't injected enough vessels to see the fistula. But if it's in that time, then whatever symptoms they have are not related to venous hypertension, and therefore there's no dural fistula. So this is a global arch injection. You can see on the image on the left the actual feeder, and very subtly to the left of the aorta we see that little windy vessel, but it can be quite hard on global angiography to identify the AV fistula, and that's why these two images on the right are super selective injections showing the AV fistula. And the AV fistula is at the site, the transition zone between the very tortuous segment and the more contrast-dense segmental artery. All of that is vein. We see it goes up, twists around, goes up and down. That doesn't have the normal appearance, straight, linear structure of an artery. If something is twisty and turny, then it's more likely a vein, except of course for the scalp vessels. Here is the normal progression from the left to the right of injection of the anterior spinal artery and visualization of the veins. And this is to show you what they look like and how you need the temporal sequence to see, because it can be confusing, the arteries and the veins. So on the far left we have the artery ad caveats, the hairpin turn going down, the arterial basket at the base of the spinal cord on the second image, and then on the third image we start to see the veins. And you see how the veins also follow the exit at the nerve root sleeve level and are going to be a little bit more irregular in their appearance, a little bit more wavy than the typical arteries, which are quite straight and smooth. Again, 10 to 11 seconds, 10 to 12 seconds, seeing those veins excludes a dural fistula. If I go back, and the reason they get venous hypertension is they lose these lower drainage connections. So at the nerve root sleeve level or somewhere, the outlet vein thromboses, and that's why they get ascending. So they start to thrombose lower radicular vein outlets, and that progresses higher, and that's why they have the progressive neurologic symptoms. Dural fistula embolization. So when we do the angiogram at the same time, we try to do the embolization. Again, use a liquid embolic agent in the feeder and proximal draining vein. Very important. You've got to cross that AV connection. If you don't cross the AV connection, then you haven't treated the patient. So we normally do this first. If we do not succeed, then surgery is done. If the primary feeder vessel is the anterior spinal artery, then or branch of the anterior spinal artery, then typically we recommend surgery because of the risk of spinal stroke. Again, as I described before, surgery is disconnection of the vein at the nerve root sleeve. Recovery of these patients depend upon the preoperative neurologic status. So if they've been completely plegic for a year, recovery is going to be unlikely. It's also about the severity of decline. So if they've been rapidly progressive over a short period of time, then the likelihood of recovery is also less. Imaging-wise, if there's syringomyelia or cord necrosis, then obviously poor prognosis. Edema only has a better prognosis. And you got to treat these patients because it is a progressive disease that will end up in cord necrosis. Here's an example, quite complicated looking injection, but the hallmark is seeing these dilated veins, which are very tortuous and quite obvious. Super selective. Lower down, we see higher up, we see the veins ascending, and even higher up, ascending all the way up in the cervical region. And this is the patient who presented with diaphragmatic paralysis. There's the super selective injection into the arterial feeder to the dural AV fistula, and we can see this sort of mesh of arterial pedicles, but then one vein sort of from that dilated pocket there that ascends, that is the AV communication. So we need to eradicate that proximal section of that vein as well as the arterial pedicle to assure cure. Looks like that says T6. And this is the glue cast that we achieve. So we see the arterial pedicles filled with, in this case, NBCA, and that proximal vein, which goes diagonally to the right and up, filled. Another different case. The high mag view of another case showing the arterial pedicle coming in and then the vein. In this case, it was interesting. The arterial pedicle goes along the epidural space going down to the level below. So sometimes you're not fed from the same level, but from another level going down, and we see this long, thin branch coming down and then connecting directly to that vein. And again, sometimes with AV fistula, we see that transition from a smaller artery to an enlarged vein, indicating the transition zone. And then there's the embolic material in the arterial pedicle and the proximal vein. Yeah?
Do you embolize this from the arterial side?
Yes.
Or from the venous?
Arterial side. Another segmental injection. This was an interesting case because it's sort of a combined lesion. We have on the right side injection seeing a dural fistula, so the segmental artery is coming around, going down, and then we have an ascending branch which feeds the dural fistula where we see the veins. And we have another branch coming across and up going into this mess. This is actually an epidural fistula. The epidural veins are very diffuse. They're more like lakes. And so this patient has both a dural fistula and an epidural fistula. Notice the dural fistula is draining into the spinal veins. Epidural fistula, although it does drain into the spinal vein somewhat, that's the vein going from the right to the left to join the main axis. It also drains into through the epidural space into the azygos in this case. So you know, I'll go through. This is injection to the left side showing additional feeders. And this is, let's see, so this is eventually the embolization anterior spinal artery. Here's the superselective catheterization on a lateral view, showing the catheter, the segmental artery, and that one small branch, tiny branch going in to fill the epidural malformation, which drains both anterior and posterior into the ascending vein there. On subtractive view, the right side injection, again showing the arterial pedicle, that little mess, and then eventually the drainage into the epidural space. We did more super selective. There's the injection of the embolic material into that feeder. Notice that we did not quite achieve access to the pocket, so we're not done. We had to access from another route here, and eventually fill it from the second injection. You see on the right, so we see the embolic material from the right patient's right side that didn't achieve access to the epidural pouch and the proximal vein, which is ascending. We had to go from the right side, and then we achieved that. So only when you get the AV communications is that cured. We're not going to really talk about vertebral body angiomas or hemangiomas. But epidural AVMs and AVF occur, and we talked about Cobb syndrome. This is a patient with an epidural AV fistula. We see the flow voids posterior and into the left side of the spinal cord. And the sagittal we see in the epidural space. And angio, we see this very large arterial feeder feeding this network of draining veins. Again, this was treated, this is a while ago, treated with balloon and NVCA. So the balloons were placed into the fistula, and this was followed by glue behind the balloons. And then occasionally you can have flow voids in the spinal canal that are not related to a spinal vascular malformation, but a cranial vascular malformation. And this is a patient with a transverse sinus or transverse sigmoid sinus dural AV fistula, where the venous drainage, the outlet of the jugular vein has been occluded, and it's subsequently draining into the posterior fossa and down the veins of the cervical spinal canal. And that's what we see, both anterior outlining cord, anterior and posterior. Again, another view of that. Again, a picture. Another patient with a epidural AV fistula with spinal cord intraspinal venous drainage. Again, we have the superselective, that pouch in the epidural space, which then, instead of draining out like the other one did, this one has now drained into the spinal canal only, resulting in venous hypertension and a presentation just like a dural fistula. And then superselective catheterization and embolization. Okay. So, not to torture anymore. Intradural AVMs and AV fistulas. This is hopefully an old primer on those. They're high-flow arteriovenous shunts. Pathophysiology depends on the venous drainage and the size of the fistula and the location of the malformation. The primary separation is into intermedullary AVMs, perimedullary AV fistula, and dural fistula. Dural fistula and perimedullary AVFs relatively easy to treat, but oftentimes harder to diagnose, get delayed diagnosis. Intramedullary spinal AVMs are typically easy to diagnose, very obvious on the MR, and dramatic clinical symptoms, but very problematic to treat. That's it. Any questions?